is Luke Lawton, one of the conveners of the fellowship exam course, and with me tonight is Peter Cass via the comments field. And welcome to our first live webinar for this particular year-long cohort of the fellowship exam. The reason we're giving this particular webinar is to have a bit of a chat about some of the framework for studying for the exam. And the background is this webinar used to be one we gave in the middle of the course at one of the face-to-faces. With the transition of the course to an online sort of model, we had a bit of a chat and decided that this was one we might put out at the start, just to frame things up. And I'll say at the start, what I hope to do here is to challenge a little bit of your thinking regarding how you study, and really set you up to get the best out of your preparation. And you might think some of what I'm going to say is a bit controversial. At no stage do I intend to be patronising. This is a slightly more difficult webinar than a didactic talk about psychiatry, for example, to give. And so very much, if there are questions or comments, we'll stop at regular stages, and you're welcome to write them in. It's a slightly shorter webinar, this one. Like I said, it's really to set you up and get you thinking about what you aim to achieve now that you've had the chance to step into the course and have a look. And to begin with, I thought I would just put out, I suppose, a couple of really important messages that I think people starting the course and starting their exam preparation need to hear. And I'm just going to talk before I go to the slides. So the first sort of message to me is that this exam is very different from any exam that you have taken prior in your life. The second is that if you are a functional emergency registrar, you already know a lot and you probably have close to the knowledge you need to pass the exam. The third thing is that there is a deliberate bias in our course away from didactic knowledge, making notes, making lists, all that sort of stuff, towards sorry, Ali, I've just seen your question. I'll come back to that in a sec. A deliberate bias towards technique and practice. And those of you who have sat the initiation exam will realise a couple of things. There's not a lot in there that's particularly hard in terms of depth of knowledge, but getting answers down on the paper is quite hard. And the fourth thing just to hold on is that there's really two critically important components of the course that we see. The first is doing the exams and looking at technique. And the second is the homework component. And we'll talk specifically about that in just a moment. So hold those ideas. Exam's different. Our bias is towards learning and technique rather than didactic sort of teaching. You already know heaps, and there's a couple of really important things to take on board. The background to this course, for me, is to do with my preparation. I actually, and this is something not to confess necessarily in a fellowship course, but failed the fellowship exam the very first time I sat it back in the old days. Passed the written very handsomely and failed the clinical exam. I'm having a BBC moment here. I am, mate. Talk to you soon. Excuse me, please. The reason I failed, one of them, I got a case of polio on the short. So that's a good example of how unfair the exam can be for me. I've seen one case of polio in my entire medical career, and it happened to be in the fellowship exam. Sorry, my son has just distracted me for a moment there. But when I came back to sit the exam again, I sat down with a group of blokes, friends of mine, and we prepared. And we would prepare by writing each other questions, and then ideal answers for those questions, and we would test each other on a rotating basis. And I found that a very effective method of studying. And I suppose, and I'm not meaning to speak for Pete at all, but Pete and I have put this together because over the years we have seen a very large number of people who, in our opinion, have been given very bad advice when it comes to preparing for the fellowship course. or no guidance at all. And the big challenge in preparing is to step back and look what you're being asked to do. And that's why we start with an initiation exam. Because what you're being asked to do, unlike every other exam you've sat, and every other exam you've sat probably looks something like this. Here's a textbook with some specific information. Learn as much of that as you can, or learn as much as is possible, and then write it down. And we'll mark you on how well you write that down. Right up into the primary exam for the College of Emergency Medicine. This exam is a bit different. If you look at the initiation exam and just reflect for a moment, I'd suggest to you a couple of things. The first is there's questions in there like write a procedure for pacing a patient, or here's a patient with a fever and sepsis after a polypectomy under colonoscopy. Neither of those things are things that you will find in a textbook in any format that you can write down a list and regurgitate to us. The exam is about translating the knowledge you have and putting it on a piece of paper. One of the keys to the exam is being able to do that successfully, and that's where the technique and practice element really comes in for us, and that's why our bias is that way. The majority of people practicing in emergency medicine coming up to the exam, good evening Liz, will realise that a lot of the stuff they're asked is actually stuff they do most days. There's always stuff you don't know, and you need to find that and correct the deficit. But a lot of this is about your everyday work. And if we step back and we go on to how people tend to feel about the exam, these are words that sort of come up all the time. And one of the problems with emergency medicine is that we touch upon so many different disciplines. You could get O's Intensive Care Manual, Harrison's Principles of Emergency Medicine, Scott's Surgery, and spend years and years and years reading them to learn everything. You find a couple of things. The first is you would be reading a lot of stuff you already knew to some degree. And I think that's one of the cardinal mistakes people make in investing their time that leads to a lot of this stuff on the screen, is that they study stuff they know, which is very cognitively sort of pleasurable in one sense, because you read something, you go, great, I know this, I can do it. It's much more confronting to find something that you don't know and realize you don't know and then have to go and learn it. But in fact, that finding what you don't know is the best bang for your buck. And that's one of the reasons we use a questions-based approach. And we, over the course of the exams that we set, and the point of the exams that we set, and the point of the questions every week is to pick up major topics and make sure that you are able to answer those questions. And we've sort of put all the stuff in there that we think is by far the most likely stuff to come up. And if you are answering one of those questions and you're struggling, the key is not to stop and start. The key is to work down everything you know and then go back to the book after you have finished the questions and fill in the gaps, because that's how you find what you don't know. The other sort of really big cognitive trap, along with studying what you know for the exam, and that's conventional study. I'll go and summarize a textbook, which is a summary anyway. I'll make some beautiful notes. I'll spend a huge amount of time, and I'll feel better because I've done the time, and I'll spend the time on what I know, and I'll feel better again, but I'm not actually being productive. So that's one trap. The other cognitive trap is ending up following sort of down a rabbit hole. And because ED touches on so many things, you can really end up taking subjects to extremes, and there's a real danger in that as well. Particularly when it comes to, we've had arguments, or not arguments, but heated discussions over the time of this course with people about things like, what the true metabolic pathway of morphine 6-glucuronide is. Now that's completely irrelevant. What the relative frequency of causative organisms for bronchiolitis is, maybe a little bit more relevant, but it's very easy to get into detail and detail and detail and detail. And so the question is, how how do you avoid that? So we'll come back to those ideas in a sec. Is everyone following me so far in terms of some of the ideas I'm throwing out? Pete, do you have anything you want to add at this stage? No? All right, cool. Why do we do homework? And homework, I just wanted to, oh, sorry, Pete, I'll let you go quickly. I will try and do that. Sorry, Pete, I am not under your image next to my name. Yeah, I'm trying to. It's not letting me turn it on, mate. I'm sorry. Sorry, everyone, excuse us. We don't usually do the webinars together. Just give me a sec. Sorry, Pete. Before we go again, 2 more seconds. If I can't make this work, we'll keep going. Discussion. Okay, now we'll just check and see. No, Pete, sorry, I can't make that work. I apologise. I'll make presenter. Hold on. No, look, I'm going to continue. I'm sorry, Pete. Okay, great. I apologise for that, everyone. Like I said, we don't usually do these together. So look, stepping back for a sec to the ideas. So how does all that fit in with homework? Yeah, that's a good idea, Ali. Thank you. So Pete, I do have my mobile here, and we can try that if you want. I can go on to speaker there. So look, why do we set homework? And again, the homework's got that sort of high school conventional homework that we want you to do so we can mark and give you grades. But one of the keys with homework is using it as an opportunity to do a different sort of learning. And if you have watched the first webinar dissecting the initiation examination, you'll see that it's actually important to understand what's contained in the questions. And the answers there are really interesting because it's very difficult to write SAQ questions without without giving away a whole heap of hints within them. So that's one. The second idea is that each of the SAQ questions, and the examiners say this, is that the way that they put the cases together is that they take a clinical case and then build the questions around that. And what that means is that an SAQ is not a series of random questions that appear one after the other, or it shouldn't be. They should be centered around a clinical case. The point there is that centering something around a clinical case means that there are certain givens that have to remain constant. So the patient with a painful red eye and loss of vision can't change in the next question to a painless red eye with loss of vision, and can't change in the third part of a question to a head injured patient. So there's things that flow through the questions. And there are certain sequences of questions that lend themselves very well to being written together. And they're questions like, here's an image, give a differential diagnosis, and how will you investigate further? Or here is a significant amount of clinical information, we would like you to manage a problem. There's not a lot of crossover between those because it gets very difficult to put those questions together. That is not something you get from reading Cameron, Dunn, or any of the other textbooks I ignore. And in fact, if you own a copy of Tint and Alley, I'd suggest you go and burn it. the way you get that knowledge is by taking a case and saying, well, how do I actually ask a question about this? And to give you a good example of that, go back to the colonoscopy question from the initiation examination. There's no textbook that gives you a list of specific differentials for a 54-year-old man who's had a colonoscopy and now has sepsis. You've got to actually generate that yourself. So it's a very different way of thinking. And when you're approaching the examination questions, in contrast to that conventional examination I spoke about earlier, where I ask you a question and your aim is to work out which page of which textbook I'm referring to and regurgitate that, you need to step back. And when I ask you a question, what I'm asking you to do is to demonstrate and apply your knowledge. And the only way you get good at that is both by answering the questions, but also understanding how they're put together. Additionally, the homework offers, in our opinion, a particularly valuable opportunity to, I suppose, again, to study what you don't know. And things that I was bad at, for example, were, when we were talking about endocrine stuff, I didn't, like I think I do now, know a lot about thyroid emergencies. So I would actually write questions on thyroid emergencies to force myself to say, here's a topic. How could I pull this apart and write a question on it? And then how do I put that back together? And one of the benefits of learning about a topic you don't know that way is that you start to realize there's only certain things that you can be asked in the context of an SAQ about that topic. It prevents you going down those rabbit holes I spoke to you about earlier. And there's a lot in the course itself. People who are sitting the exam, I think, have a really good sort of notion of, if I do a certain amount of study or if I make a certain amount of notes, then I will pass the exam because I deserve to. And you need to divorce yourself from that and step back and say, look, what are they actually going to ask me? They're going to ask me to demonstrate that I know something and apply it and I can put it on a page so I can be marked. Very, very different. They're not going to ask me minutiae. They're going to ask me for concepts, understanding, and a whole lot of other stuff like that. So when it comes to the homework, there's a couple of reasons we really advocate doing it. It's probably the most important part of the course. I don't really mind if you don't watch the video on Module 7 of me talking about permissive hypotension, a variety of other things, but the homework to us is really one of the most valuable things, and that's born out of both our different experiences, but our shared philosophy when it comes to approaching the exam. So it really is an invitation to take something you're not good at. If you're writing homework on topics you know well, you're missing the point. You should be writing on topics that you don't understand so that you pull them apart and work out what you don't know and what you need to know. It reinforces your thinking when it comes to the exam about sort of the questions not being abstract questions from a textbook. They're questions centered around a patient sitting in front of you in the ED, and that's a really critical cognitive shift to make. Because once you realize that, you start to visualize the patient in front of you and you can tap into all that stuff you already know by thinking, what would I do with this person in front of me in the ED where I work? And like I said, it gives you a feel about what the questions sort of tell you and don't tell you and a few other bits and pieces. So we actually think it's really important. Pete, I know, is going to go through some of the homework soon and provide a bit of feedback generally to the group. I also sent a brief circular around based on some of the homework I've seen. When we do that, our aim is not to pick out individuals and sort of mark their stuff. Our aim is very much to challenge your thinking and demonstrate how the questions end up put together themselves. So that's the point of the homework. And like I said, the next slide really is just about reinforcing to me some of the differences in what you've done, which is very didactic teaching, versus applied teaching or applied knowledge, didactic learning versus applied learning is what you've got to do here. And the sort of didactic stuff is, list the elements of the Wells criteria, describe how you interpret it. If it's less than 4, you can do a D-dimer. If it's more than 4, you've got to investigate. Somewhere between them is, look, how would you image someone for suspected PE? Whereas the applied knowledge, which is what you're going to be asked, is very different. Of course, they're going to give you a clinical scenario. Here's a 44-year-old man with a history of DVT and chest pain with some vital signs. How do you investigate him and why? And it's testing the same knowledge to some degree, which is, can you calculate a Wells score and do the right thing? But it's testing it in a completely different fashion. And to a large degree, although there are certainly lists of things in the exam that it's good to know, the challenge is being able to translate that to applying your knowledge in an exam setting. And sitting around that, and this is, I suppose, a metaphor I like to use, but one of the big questions we've always had, and it's a good question, and it's one there's a difficult answer to some degree, is how do you study for the multi-choice? And so when I think of the sort of way the topics are set up, I'd put it to you that there's a whole heap of big topics. If we took ED cardiology type stuff as an example, the big topic is how you manage ACS. How do you risk stratify it? What do you do with a STEMI? Centered around that, there's a whole heap of little sort of factoids that lend themselves very much to multiple choice questions. Which of these is not a component of the TIMI score? If it's trauma resuscitation, what are the numbers from CRASH 2? If it's a kid with a wheeze, which of these organisms is most likely to cause it? And it's easy to see the big topics. The question is, how do you pick up the factoids? So that's just something else to have a think about when you're studying what you're trying to achieve. And we'll come back to that in a sec when we get to the multi-choice questions. But the big topics are the ones that tend to be SAQs and OSCEs. And they're usually pretty easy to pick out. You're in the exam when it comes to the cardiology perspective, never going to be asked to discuss the New York Heart Failure Scale. You're never going to be asked, to interpret a CTCA and discuss whether clopidogrel or ticagrelor is a more useful drug. What you're going to be asked is, look, here's an ECG with an abnormal finding, which is a very common way that you'll be asked something. How do you interpret it? Based on your interpretation and the diagnosis you have made, Wellens syndrome, De Winter's T waves, and anterior STEMI, what is your management? So it all flows through. One of the things you've got to think about is how you apply your knowledge context. I think I've made that point already, but I hope everyone remembers it, and I hope that when you're writing your homework questions particularly, you start really getting yourself into the habit of thinking about what the actual case is, because once you've thought of the case and the condition, there's only certain things you can ask. So when it comes to the knowledge for the SAQs, and this comes from one of the examiners I've spoken to over the years, there's two sort of ways to cut your knowledge, if you like. So you can sort of pull it apart and discuss breadth, and that lends itself very much to diagnostic type questions. How would you investigate something? What are the pros and cons of these three mechanisms? What are the possible differentials? So you're being asked to show context and perspective about an issue in the context of a wider issue. And the way you pick those questions is usually there's not a lot of diagnostic certainty given to you. And a good example of that is the PE question we've just talked about. Here's a 44-year-old bloke. He's got some pleuritic chest pain. How do you investigate him? We're not telling you what's wrong with him. The other way you can cut that knowledge is in terms of depth. And that to me tends to be the management type questions. So here is a patient with an ECG abnormality. It's an acute coronary syndrome. How are you going to manage him? Here's a septic patient. What are the important elements of your management? And those questions sort of signal themselves by giving you lots of diagnostic type pictures. So here's an ABG that's diagnostic. Here's a CT that's diagnostic. Here's a STEM. with very clear conveyed information. The patient's septic. What are we doing? So you need to take your big topics and be able to step back and look at them in context, pros and cons of imaging investigations, differential diagnosis for a child with abdominal pain or a child with a sore hip. And like I said, you need to be able to take topics, septic patient, and work them out into great detail. And again, if you step back and think of that, that's not something you're going to get from Cameron Tintinelli Dunn, whoever it is. That's something that you get by taking the knowledge you gain every day and being able to write it down. And it's interesting because I reflect to you thinking about the initiation examination. If we were working together on the floor and you came to me and said, look, I've got a 50-year-old guy had a colonoscopy yesterday. He's got a peritonitic abdomen, a fever of 39 and real pain. And I said to you, what do you think's going on? You say he needs a CT. I think he's got perforation. And I would bet good money that almost 100% of the people taking the course will reach that conclusion, which is not a hard one to reach, in the course of a clinical shift. And I will tell you that less than 50% of the people who take the course when they start manage to articulate that in the context of a fairly straightforward examination question. So if you're not thinking about what you're actually trying to achieve with your study, which is showing that you understand context, detail in the setting of the case, you're missing the point. A brief word about props. And I think, again, people, for a variety of reasons, go to textbooks for their study and they go for lists of things. Here is a list of the ECG changes in Wellens syndrome. You see deep biphasic T waves in the anterior leads, yada, 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 yada. And you read that in prose in a book. Here is a list of the features of aspirin toxicity. And it causes these abnormalities: a raised anion gap acidosis with a primary respiratory alkalosis, and a couple of other different things. But that's not how you get tested on that stuff. You don't get asked to make a list. You get asked to interpret something that's given to you. They're not going to ask you to list the ECG features of Wellens syndrome. They're going to show you an ECG with a Wellens syndrome on it and ask you to diagnose it. They're not going to ask you to list the metabolic disturbances of aspirin overdose. They're going to give you an ABG and a history of overdose and expect you to know that the only overdose that presents with a primary raised anion gap acidosis and a primary respiratory alkalosis is indeed a salicylate overdose. They're not going to ask you to give the radiologic, write a paragraph description of a Colles fracture. They're going to give you an X-ray and ask you to interpret it. And so I think, again, and I'll share with you, and when I prepared the first time for the fellowship exam, I started with Cameron and I spent about 5 weeks and I got a number of chapters in and I thought, I'm wasting my time here, because when I went and turned my mind to the questions, none of what was in the cardiology questions that ASIM had actually asked was in the textbook. None of it. It was all about interpreting ECGs. And the only way you get good at that is by practicing props. We've got a heap of props in the practice questions for exactly that reason. And again, that's our bias towards technique and preparing for an exam rather than going back to sort of medical school didactic learning. There's also everyone, and it's important that you understand, has the opportunity to do this stuff every day at work. I do a floor shift, I get shown about 20 ECGs during the day. I do a number of blood gases during the day. I do heaps of CTs that I look at. And if you're not taking those opportunities to practice at work, you're really missing a valuable investment in your success. And that's not about sitting down for 20 minutes and reading about an ECG. It's about looking at it and practicing writing a brief description of it over 60 seconds, because that's what you've got to do in the exam. If you're looking at a blood gas at work and you're not taking the time to calculate out anion gap delta ratio, expected compensation, it should only take 2 minutes. Again, you're missing the chance to practice. If you're not looking at the CT scans and x-rays of your water and attempting to interpret them before you actually read the result, same thing. And that's really important to say. So don't, by any means, put down all the props to go to the books. So that was sort of my little SAQ piece to challenge you. I'll stop just for a sec. Does anyone have questions about what I'm saying there? Like I said, I appreciate if what you're hearing from me is spending hours a week summarizing a textbook is stupid, then you are hearing me correctly. If you are hearing me say to you, practicing the questions and understanding how you translate your knowledge to a piece of paper, so someone sitting ages away, both in time and distance, can tick it and give you some marks to allow you to score and pass the exam, then you were hearing me correctly. Yeah, great. It's me too. If you are hearing me say spending time studying the stuff you know is silly, it's easy, but it's silly compared to spending an hour studying the stuff you don't know to improve your knowledge of it, then you're hearing me correctly. Yeah, thanks, Pete. And finally, if you're hearing me say, if you don't understand how you put it all together, then you're missing a whole heap of valuable cues in the exam. Because the object here is, emergency medicine. If you're not up before the coroner or APRA, you've got to know what you're doing. The object here is to play the game and get it on a piece of paper and allow the examiners to pass you. Step back and look at what you've got to do. So, and in comment, sort of Liz's comment about hating textbooks, this is Cameron, and I had textbooks too. And one of the problems when it comes to the multi-choice type stuff is it can be really hard to work out what the hell you're going to be tested on. But I'd suggest to you, and if you look at the page I've got up there, reading that page is incredibly low yield for the time you put in. Because most of it's like a fireside chat about sort of understanding a whole heap of stuff, and it's all in prose, and you get about bugger all out of it. So how do you study for the multi-choice? And this comes back to those ideas. How do you get those little bits and pieces? And that's a bit harder. The factoids, and look, they can be horribly, horribly unfair. And I'll share with you from one of the exams I sat, there was a multi-choice question on 4 mathematical formulas. Which of these defines standard variance of the mean? I thought it was a bit funny when I started laughing at that. I had no idea, but I picked C, which was correct. To something about Hymenopterous stings, which turns out to be wasps. And there's always going to be stuff that you don't know, particularly in the multi-choice questions. The multi-choice to some degree tests breadth. But again, what I'd suggest to you is that trying to read Cameron and trawl through all that sort of stuff to pick out a couple of bits is, again, really low yield and not a good use of your time. So, a couple of ideas. Where do the multi-choice questions come from? And the answer, unfortunately, is Cameron, generally speaking. So that's one. And if you're Pete, who used to write multi-choice questions, and you're asked to do that in your spare time, how do you do that? And the answer is you go to stuff you can find easily and fix easily to change a couple of bits and pieces. And even though the multi-choice questions are now ostensibly more clinical based, that still effectively means tables, figures. They're the things that are going to be the basis for the questions. So when you step back and look at how the questions are written, they're written by ordinary FACEMs who don't have hours and hours and hours to spend on each question. They've got to get 5 questions in by the end of the week for the SAQ or the MCQ committee. They're going to get a grade. I'm just going to pull out Cameron, look at this table on, take a pick of relevant subjects, grades of heart failure, I'm going to write, okay, so New York class 3s can't walk very far, has chest pain, often at rest or whatever it is, and you can tell that I don't really care about that. So I'm going to write, here is a patient who has chest pain at rest, can only walk 20 meters, and history of heart failure. Which of these grades is? And that's how it happens. So when it comes to preparing for the MCQs, our suggestion very strongly is that you go to the tables, the figures in Cameron, spend your time looking at those. So that's one. The second is you do as many MCQs as you can. We've got heaps in our course, and you'll notice that some of the MCQs are really in depth and some aren't. But the point of the MCQs is not necessarily that each of them is a written textbook for you to read. The way, I suppose, certainly I studied when that came to the MCQs was I'd do a lot. I'd find ones I didn't know, and I would go and read that specific little bit of information. And a really good tool for that is downloading eMedicine. I'll add it onto your mobile phone because you can search by topics and by epidemiology, workup, presentation, pathology, treatment, etc., etc. And so if the question was about the etiology of angina, completely irrelevant, who cares? That has never changed my practice as an emergency physician. But it's potentially on the exam, so okay, great. I'll go and read the paragraph in eMedicine on the etiology of angina and get that together. So that's really important. And so over the course of time, what that means is that you hopefully have those little stars, as my next slide says. You put that together into a big picture, and you actually form a really good knowledge base to approach the MCQs. The other bit there is when you're writing MCQs, and again, particularly around some of the tips and tricks that come into them, is to take the tables and figures, the high yield stuff, as I've just suggested with my somewhat ad hoc example of New York heart failure criteria, and write a question about it. And how would I ask a question based on this? It's not just here's some irrelevant clinical shit, here's 4 options. You got to turn that into here's a brief clinical vignette that clearly points to one of these 4 objects as the correct answer. And again, that's useful for getting a feel for how MCQs are put together. And the last point on this slide, the hard facts file, is one of Pete's, and it's an idea I really like as well. And you start finding little bits and pieces of information that repeat themselves over and over and over again. And as an example that all of you will probably recall from the primary, you might recall that metoclopramide increases lower esophageal sphincter tone. Comes up again and again and again in questions. And those examples exist in the fellowship. And so when you find a particular factoid that you think, gee, that's really high yield, write it down as a single sentence somewhere so that when it comes to just fact recall, if you've got nothing else to do, and if you want to use Anki and flashcards, that's fine. If you want to use a pen and a piece of paper like I do, that's fine too. You can just look at your notes and go, okay, here's a whole heap of facts that I might get quizzed on. That's really high yield, quick revision. That's worthwhile as well. So I know that seems a bit like a funny strategy for the MCQs, but if you understand where they come from, that's one. If you're good at reasoning your way through them, which comes from writing them, that's 2. And you're sensible, and again, you just spend your time focused on little bits and pieces over the course of what is a long game, studying for the fellowship exam. It's a long walk, it's not a sprint. You build up a heap of pictures, and you actually, and if I'm honest, I've got no idea how I passed the MCQ twice, but I did happily by doing this. There's always questions you don't know, and they're those rabbit holes I talked about earlier. You can follow things through, and then you find conflicting sources and think, geez, what do I do? This book says A, this book says B. But if you can stop yourself getting to that point and look at enough questions, you build up enough base to answer it, and you recall it on the day. And like I said, so the analogy to sort of complete my planets and little moons analogies, if you do enough of that, you actually start to build up a very coherent picture. So that's my sort of 40-minute pep talk for the fellowship course. Hopefully, it gives you um, a bit of framework for what we're trying to achieve. Because the sort of classic, I think that a lot of people get from the DMTs in the hospital, and I say that as the director of a tertiary ED, and we don't, I hope, is just go and read Cameron and sit in LA and you'll be fine. Good luck. I've observed over the years that is incredibly bad advice. And my advice is step back and look at what you're trying to achieve. You're trying to pass a particular exam which has rules, tells, techniques, and ways of asking its questions. Understand that what you're not trying to achieve is sort all this out by Friday week. This is something that you need to put together over the course of 6 months, 12 months. In my case, the first time I sat and passed it in 3 months, and I had a trip to Vegas in between, probably why I forgot to revise polio. But it's stuff that it can be very difficult when you're in the middle of working through it all to see what you're achieving. And Ali, that comes back to your question. And we used to say, look, get through the course in 6 months, modules we had, and consistently we would find that people were falling behind. Of course, it's quite, by the time you're writing questions, going through, taking the time to look up what you don't know, doing practice exams, there's quite a bit in there. So we recommend each module over the course of about a fortnight, particularly to give you the chance to do a couple of things. And the first is do the homework properly. And the second is take the SAQs, MCQs as a serious test every week so that you are in game mode from module 1, module 2 or 3 or whatever you're up to now. But be aware that what you're trying to achieve is not an overnight thing. Again, it's different to most exams. If you're like me, you did 3 days study, before your high school chemistry exam, you were good, you pass. This is not like that. A large part of your learning journey here is not about picking up knowledge you already know. A large part of your learning journey is about learning to translate that knowledge under time pressure and certain conditions onto a piece of paper to get marks. Certainly when we do the ABG talk, where we've done that, and that's the one I think when it comes to not sweating the small stuff, people love to throw up, but what if this patient is a smoker with emphysema and they're vomiting and they've got diarrhea and hot, then you can sort of cool. Okay, come back. You can sort of tie this all down and end up, getting your head stuck in a knot over it all. What you've got to do is work out where the limits of that is. So when you're starting to think, I'm just going over and over the same piece of minutiae again and again and again, and I can't get, take your pick of, the molecular mechanisms of adhesins in gram-negative sepsis straight in my head. That's probably the time at which you should step back, look at yourself in a mirror and say, hey, you know what? I probably don't need to know that much for the purpose of the exam. And if that's something that you're interested in, if it is good on you, because the world surely needs people who are interested in that, go have a read of it when you've dispensed with the exam and make that something you study as a consultant. So when you get to the minutiae that you're really struggling with, you have permission to step back and say, stuff it. That probably doesn't make a big difference anyway. And even if you get asked about that particular, is it adhesin gamma or delta in the exam on the multiple choice question, that's one question from 60. Big deal. And you're at least a 1 in 4 chance of getting it right. So having a bit of perspective about that stuff is really, really important. Again, hopefully a constant theme you've picked up from me in this talk is that learning for this exam and passing this exam is doing practicing. You're not going to get asked an SA cardiology question. You're going to get given an ECG, almost certainly for cardiology. If you get a respiratory question, there's a really good chance it will include a chest X-ray. A toxicology question often includes an ECG or a blood gas. A general surgery question often includes a CT scan of something. Trauma questions often include clinical images. Dermatology is almost exclusively asked by the use of showing you a photo of a rash and you sitting there and thinking, I've got no idea what the crikey hell that is. Happens to all of us. But if you're not practicing and thinking about that stuff, again, you're missing the point. When it comes to your homework, and Ali, I see you're in module 3, like I said, everyone's on their own timeline, the way around the course these days. But if you're practicing it out, take the time to get the homework done, have a think, and obstetrics, one of the first modules is usually basic questions around how would you manage labour? And that's something most of us are uncomfortable with. So go write a question on that. But use the homework to pull apart things you don't know and to focus your study on areas where you need to improve. Don't go trawling for little bits of information, factoids through textbooks. Do the questions, find out what factoids you don't know, and learn them based that way. Over time, that builds up to a picture. Make a hard facts file so you can recall them easy when you do find them. And the last 2 points are really, really important. There is always something that you can be asked about that you don't know. There is almost certainly in the exam the chance you'll be asked a question you do not know the answer to. Sounds hard. It's easy for me to say. I've done the exam years ago now. You've got to deal with that. There's always, the key is not to throw away the 29 questions you do know and do poorly on them, of course, of the one question you don't know. The other key is for the question you don't know that you're able to look at the question, take everything out of it, and still score as many marks as you can. And particularly when it comes to going down those rabbit holes and starting to read papers about whether NORAD, adrenaline, dobutamine, or dopamine is better for type 2 cardiogenic shock, you probably don't really need to know a lot of that stuff. You just need to be able to give a sensible choice and demonstrate that you're safe. So, Pete, that's sort of what I had to say. I don't know if you want to try and do a bit of a summary via mobile and we can give that a go. Here we go. We'll see if Pete can come on. So, Pete, you're on speaker now.
Hey, how you doing? Okay, I'm going to see if I can activate my camera here, and then I'm going to play this.
On you.
See if this works.
Can everyone hear Pete with me doing that?
Okay.
Oh, Teddy can't hear you. So we can see you there. Just talk again. Only through the phone. You sound like a Dalek, Pete.
There's going to be that, unfortunately, that kickback in the system. That's awful, isn't it? Why is it doing that?
I don't know. I'm sorry. I don't know why I can't get your microphone up. Yep, cool. Sorry, everyone. We'll just see if we can get Pete on very quickly. If not, we can see about getting Pete to sort out another webinar quickly. Yeah, no, same problem. No, and I think we've lost everyone now. Okay, do you want to type? Yep. Can everyone hear me again? Or have you lost me as well? Oh, yeah, Liz, you can hear me great. All right, I do apologise. Sorry, like I said, we'll have to give this another go, Pete, in terms of working out how we both get on here. Like I said, we normally split it up. We're just both available tonight. Sorry, Pete, can you, I've given you screen control, so hopefully you can hear. Can you, do you want to talk and just see if you can activate your, no, no, hold on. Just try that again.
Actually, why don't you just hold it up to your ear and I'll talk to you and you can just tell them what I'm saying.
Yep, cool. Tanya, can you, yep, okay. I think we've got you.
Okay. So look, one of the things I want to say is that there's a difference between strategy and knowledge and regurgitation.
Hey,
You
Pete.
have all the strategy in the world, yeah?
Very quickly, you don't have a microphone under your video that says audio, do you? Oh, okay. Yeah. No, sorry.
It won't let me activate my...
No, that's all right.
I can make myself a presenter, but that's all it'll let me do. So what I was going to say is you can have all the strategy in the world, but if you don't have the right knowledge, you're not going to pass the exam. So there's a difference between regurgitation, which is what Luke was talking about, and having absolute knowledge. And the knowledge is about getting the important things together and applying them to the question that you're being asked. So a lot of people are saying, oh, let's get on to learning, and this is the most important part of the course, teaching you about how to study. So Luke talked about stop studying the stuff you know and studying the stuff you don't know. And that's what strategy we can use. And I've mentioned this in the lectures before. Put 20 minutes, 2 hours aside on a Saturday morning, pick 10 topics. Write down everything you know on those topics. What you don't know, at the end of those 2 hours, go and replenish. And then you have to do the questions. Now, I will say this, and I know Ali said, you've tried it, you haven't written any questions. If you write questions and do the homework, the chances of you passing this exam increase exponentially. If you listen to the videos and just do the questions we said every week, you may or may not pass this exam. Writing questions is the most important part of this course. But writing questions based on understanding how questions are written, and you only get that when you write more questions. So you will understand how the examiner writes MCQs when you've written some. You will understand the significance of every word in these SAQ steps when you've written them. The whole idea of the course is we give you the big stuff that you need to know and test you on it. When you write your own questions, you fill in the gaps and you start to think about how to interpret your knowledge or how you want the person answering the question to interpret your knowledge, and you get that extra bit of insight into what the examiners want. I think Luke and I can't stress this enough. This is one of the most important things you're going to do. People say, how am I going to get through each week or each module? What am I going to do? Design it so that you do no extra time. Some people in the past have come to work. When they get to work, they set themselves an extra hour before they start, and they go through the videos on their computer at work, and they do some MCQs. They leave the SAQs and that for when they get home. Try and find some way where you get the work out of the way, but it then allows you to put the time into be doing the setting of the questions, which is the most important thing. Case-based discussions are the important thing. And as Luke said, if you have these patients in your ED, you come up with DD. But some patients, because this is an exam, people freeze up. And so, look, I've been on the phone to people that have passed their exams. I've been on the phone to people that haven't. And invariably, one of the most concerning things is people that haven't got their exams haven't done the homework. And there's not a lot of them, but they haven't done the homework. When they do the homework, they get the exam. Okay, so I think Luke and I can't stress enough. What he talked about in terms of hard facts file, using the list for the MCQs and all of that, all important. Do as many questions as you can, and they don't have to be perfect. You will get perfect as you go along in the course. I think I'll stop there because the feedback is rather me crazy.
Cheers, Pete. So look, and I was going to say exactly what Pete's just said. Yeah, one of the things we see often when we see people who have done the course and still struggled, we say, look, did you do the homework? And the answer is no. And the homework, like I said, yeah, that traditional sort of learning model, yeah, it's not writing summaries, not reading textbooks, but we really feel strongly about it because, yeah, if you really want to learn stuff, you got to learn the stuff you don't know. Um, and understanding how the exam is put together and understanding how highly smart people who do this every day successfully can't write it down on a piece of paper to prove to someone else that they know it is something that fascinates us. And so our course is sort of our attempt to try and bridge that gap, which we actually see as one of the biggest things that stuffs people around. Um, uh, I think we probably so that's been almost an hour, and the idea of this webinar really was not to teach didactically, but we found when we give this talk, generally speaking, at the face-to-faces, and it's easier to give face-to-face because people can shout out and ask questions, but very much it's to invite you all to think about what you're trying to achieve and what that looks like. So we might leave it there. Yeah, when you go away and think about it, happy to take questions. Oh yeah, sure, Liz. Go for it. But yeah, when you go away, think if you've got the questions, very, very happy to um, yeah, the email them and we can put them up on Facebook for everyone to discuss. But yeah, really just think about what you're trying to achieve and step back. So Liz, yeah, please go ahead. Um, uh, I think basically the idea is you either just upload a PDF or a Word into the Dropbox. Um, if you want to take screenshots of handwritten homework, that's fine. Like I said, we're not running a um, we're not running a high school. If you don't want to do the homework, that's your business. But we would suggest you do it. And we sort of skim through it to look for big themes to present as learning points. But however it gets into there as an upload, that's fine. Does that answer your question? Yeah, right. Cool. All right. Well, look, we'll leave it there. We don't like to do these for uh, too long. Sorry, Ali, go ahead, please, if you need to. Um, of course, we appreciate seeing in front of a computer screen is a bit hard. I will stop recording and download the video for everyone. You know where to find us if you've got questions. If you're struggling, and that's part of what we do too. So, and we'll be in touch uh, with some more webinar dates. The next step for those of you who've done the initiation roadblock is to get into the interlude exam. That's when you do yourself. Uh, we can't mark everything, I'm sorry, but the idea is that increases your exposure to the questions. And again, comes back to what we just talked about. So good luck, keep it up, hold the frame. It is a long journey, but it's eminently doable. Good on you. Pete, thanks for joining us. We'll suss out this quick meeting stuff and see if we can sort it out, hey? All right. I'll stop recording now. Thanks, everyone. Bye.